Hello, friends. As promised, today I have come up with another instrument, a very important one, that is forceps. Though the art of forceps is fading away, some still use this very nicely, and we all must know how to use this. And it's definitely a viva question in the exams. You all must know this. In emergencies, at least, you should know how to use a forceps. So that's the purpose of this particular talk. Let's look into this without wasting time. Non-viscid art. That means not by force, but by skill. Even though the name suggests forceps, it's not for force. It's an instrument, it's a tool to deliver very tactfully and with art. Let's look at the basics. This is something like undergraduate class, but even postgraduate should know this. Design of forceps. It has got different parts. Number one is handle. Handle can be of any design, of any length. Doesn't matter much actually because it's to have a nice grip. That's all. Then there will be a lock. In lock, we have different types. English lock, Simpsons, and other one is French lock, but is Tarnier. Basically, it's a sliding lock without any screw, or there can be sometimes the screw. Sliding lock is always better because you don't fix it. You can slide depending upon the blades. That is the better. Shank, 5 to 7.5 centimeters. It depends upon whether it's an outlet forceps. Outlet forceps is 5 centimeters and low cavity forceps will be 7.5 centimeters. Sometimes mid cavity will be also 7.5 or slightly more. Again, this is the one which decides the length of the forceps. The blades are usually almost of the same size. They won't differ much. These are typically the left and the right blade. And these are the ones which will go and grip the head of the baby. And they are slightly curved. As you can see, there is a pelvic curve which is concave upwards to accommodate the J-shaped care of the curve of the pelvis. And again, concavity inwards because to have a nice grip on the head. So this is how we identify the blades. And usually sometimes in the exams, you are asked to identify which is the right and left blade. The best way is to first lock them and hold in front of you like this. So then it is very, very easy for you to make out whichever blade is on the left side of the mother is the left blade, right side of the mother is the right blade. Another simple technique is the left blade is always the lower blade. As you can see, when you hold, of course, you have to hold it concavity upwards, not the convexity upwards. And or what I would, in a simple way, tell the students is that when you position, if sometimes the examiners are tricky, they give you only one blade and ask you to identify that blade. Of course, when you hold the blade in front of you, again, concavity upwards, and you see towards which the concavity of the baby happens. So then it is very easy to identify. Or the best way is to, if a single blade is given to you, keep it on the table. If it falls, then you know it's a wrongly held blade. So if it stays there, then you look at where the curve is pointing towards. So always, of course, when you hold the left blade, the left blade, when you apply first on the mother's side, it is curving towards the mother's right. And when you hold the right blade, it is curving towards the mother's left. So that's easy. All right. Anyway, I don't have a forceps here, otherwise I would have shown you, but I hope you understood what I said. So there is a fenestration. Earlier, the fenestration was not there. This is the fenestration. This is specifically to, so that the soft part bulges out of the fenestration. Otherwise, it will be just compressing the baby. Solid is not used anymore. That is just for mentioning. As I just now mentioned, the left blade and the right blade. Left is always the lower blade, tipped upwards and to the right. So always the concavity should be upwards, and left blade, it will point towards the right. See, imagine the mother in front of you. When you use the left blade, and it will point towards the right. And when you use the right blade, it will point towards the left of the mother. Then the distance between the tips is 2.5 centimeters. It doesn't meet at all. This is purposely done so that, there won't be crushing of the head. And the widest diameter is 7.5 centimeters. You all know that the blades go and at the bitemporal diameter, and bitemporal diameter is 8 centimeters. Now, why then it is 7.5? This is to have a firmer grip. Anyway, there is no need to fear about the crushing of the head because, as I said just now, there are fenestrations through which the soft patches can bulge. So bitemporal is 8 centimeters. It has to be slightly smaller than that, 7.5, so that you have a better grip. Okay. Pelvic and cephalic curve, I have already mentioned. Pelvic curl is always upwards. Cephalic curve, left blade points towards the right. Right blade points towards the left. What are the types of forceps? Traction forceps. Of course, the main job of the forceps is traction. So all forceps are in a way traction forceps only. They can be short curve. As you can see, this is the typical Wrigley's outlet forceps. As you can see, the handle is small, sliding lock, and the shank is just 5 centimeters, and the blades are usual. Then the long curved ones, this is something like a low cavity forceps. As you can see, the shank is the longer one, 7.5 centimeters. Blades usually are the same. Handle is also slightly big. Rotation forceps is skill and forceps. I was telling yesterday that skill and forceps is almost given up by most of us. But again, there is a small attempt to revive these forceps. I personally feel there is no need to revive this forceps. Vacuum does a better job than the kill and forceps, with due respect to all the professors and teachers who are trying to promote the kill and forceps. Because this has got a minimal pelvic curve. That's why this can be used for rotating without harming the mother's soft tissues. That's what they say. First, you have to apply it, transversely. If the baby's head is transverse. So first, the application is cephalic without considering into the pelvic structures. I will come to what is cephalic application, what is pelvic application little later. And then after rotating, remove the blades and reapply the blades. This is all very cumbersome. You can damage the bladder, rectum, and so many other things. But anyway, I think I will not talk any more about this kill and forceps. So as of now, I'll put it as no. Then there is a single blade forceps. This is called vectis. This is usually used as a single blade to deeply engaged head. If your hand cannot go as low as, let's say, +2 station, if you have taken up for a very late second stage cesarean section, this blade is going to be very helpful. It's like a shoe horn. You just put it inside, and so that you can lift the head up. Always we have to lever or lift the head up. And if you don't have this vectis, single blade can be used of the forceps, not the double blade, right? So it is to lever out the deeply engaged head. Now I come to the classification of the forceps in a different way. Earlier it was traction and rotation forceps, but now ACOG classification, American College of Obstetrics and Gynecology, outlet forceps. So what are the different criteria for this? The criteria are the fetal head is at or on the perineum. It's almost there, but mother is not in a position to push any further. So you help her out instead of dragging the second stage long, especially in cases like heart disease, pregnancy, preeclampsia, where you don't want the mother to strain. So also in anemia and other situations. The other one is scalp is visible at the introitus without separating the labia, what we call the crowning of the head. And crowning of the head means you can see the maximum diameter of the skull, where the head does not recede back in between the contractions. Almost, so much of head can be visible that a crown can be put on that. That's why it's called crowning of the head. So when it is visible, it's the time to apply the outlet forceps. The leading point is at +3 station. Some books mention, Williams mentions, I think, +2. Even ACOG says +2 is fine, but I purposely put it as +3. +3 is always better. That's the real outlet. Sagittal suture is in AP diameter. Anteroposterior diameter is the best, but ACOG says rotation just less of 45 degrees also okay, but it should not be more than 45 degrees. Yesterday I was mentioning when it is less than 45 degree, if it's not a complete rotation, but and it is less than 45, or you can use vacuum. Vacuum is better, but if vacuum is not available, if you feel that mother is totally exhausted, forceps is better here, but make sure that the rotation is not beyond 45 degrees. It should be within, best is AP, but it should be within 45 degrees. Some little bit. You can just put the forceps like this and slowly rotate and bring it. It's not a rotational forceps as such when the sagittal suture is in the transverse diameter. That's a no-no for outlet forceps. Low forceps, of course, it means that head is slightly higher. It is +2 station. That's why it is low forceps. Leading point is at +2 station. Rotation is again, of course, 45 degrees or less than that. Mid forceps station is above +2, as I was telling yesterday. I have applied mid forceps when I was a junior staff and sometimes in a PG also. We used to have a axis extraction rod also at the same for the mid forceps, but in modern obstetrics, mid forceps is now deleted. Only forceps that we use in that case means one is outlet forceps. At the max, you can use a low forceps. Mid cavity forceps, Killian forceps, and other forceps are now better not be used. Now, what is the function of a forceps? Of course, no guesses, no prizes for any guesses there. That is traction. Traction is the main job of the forceps. You have to pull the baby literally down, right? Pull required is 18 kg in priming. This question is sometimes asked in the exams. That's why I've mentioned this. And 14 kg in multi. Protective cage for the head. So this is very important, especially in a preterm situation, so that you suddenly won't allow the head to suddenly pop out, which can cause tentorial tears and intraventricular hemorrhage. So you put the head in the protective cage of the forceps and very gradually and slowly you pull out the baby. One blade can be used as a vectis in cesarean section, which I already mentioned. Now I come to the applications. This is very, very important. It was so confusing to me when I was a PG, but later I mastered it. Now, when you say cephalic application, let me go slowly, try to understand this well. Cephalic application means the left blade goes onto the left side of the baby and right blade goes to the right side of the baby. That's all. Here, we don't care about the pelvic sides, whether it is left of the pelvis or right of the pelvis. I hope I'm clear. Cephalic application means simply left blade is on the left side of the baby, right blade is on the right side of the baby. Now, imagine if the head is sort of transverse, or let's say it's not completely rotated, it's oblique. If you simply put left blade like this and right blade like this, you pull it, the curves of the blades will nicely tear away one side of the pelvic wall, and it may tear away all the vessels there, and you will be in hell. So cephalic application is not the best application, right? So if it is occipitomental plane, that blade will go in the occipitomental plane and includes parietal bone and tips lie over the cheeks. This is common for all the things. Concave is towards the denominator. Convex is towards the face. The next application is pelvic application. Now here, you don't regard for the baby's head. It is simply left blade is on the left side of the pelvis, right blade is on the right side of the pelvis. Now imagine if you do like this, and if the baby was transverse, as I said, you are damaging the face of the baby. So pelvic application is also not good. Now we are in a fix. Cephalic application is not good. It will hurt the mother. Pelvic application is not good. It will hurt the baby. Then which application? Suspense. Suspense for the next slide. Of course, these things don't bother. Concave margin, symphysis pubis, and convex margin towards the sacrum, and all those things will happen. Basically, The cephalic application means left blade to the left side of the baby, right blade to the right side of the baby. Pelvic application means left blade to the left side of the pelvis, right blade to the right side of the pelvis. Both in isolation, are not good. Then how? Okay, I'll break the suspense. See, very easy. I'm the mother, or you are the mother, right? Okay. So my left, my right. Now I become the baby when I bend. So baby is exactly opposite of the mother and fully rotated. Sagittal suture is the center. So what happens? Baby's left and baby's right are coinciding with maternal left and maternal right. I hope you got it. See, when I'm sleeping like this is my left, this is my right. When the baby comes like this, just the baby, my hands, you just watch my hands. It's the same thing. Baby is ulta, isn't it? Exactly opposite. So baby's left, baby's right. Mother's left, mother's right. Both are same. When it happens only when the baby is fully rotated. When the baby is fully rotated. Now, when the baby is fully rotated, when you apply left blade onto the left side of the baby and right blade onto the right side of the baby, to your shock and surprise, the left blade is on the left side of the pelvis and right blade is on the right side of the pelvis. So they coincide. Okay? So cephalic plus pelvic application is the perfect application. And this happens only when the head is fully rotated. Then cephalic and pelvic applications coincide. I hope I have not confused you. Let me repeat. In isolation, cephalic application is wrong. In isolation, pelvic application is wrong. That means you are not regarded for the baby in pelvic application. You are not regarded for the pelvis in cephalic application. But when the head is fully rotated, the left side of the baby will be on the left side of the mother's pelvis. Right side of the baby will be on the right side of the mother's pelvis. So when you do the application, simply pelvic application, it surprisingly, coincidentally becomes cephalic application. I hope you understood. I demonstrated many times. So when the baby is exactly opposite of the mother, baby's left, mother's left are coinciding, baby's right and mother's right are coinciding. What you do, you sleep yourself and put a dummy on yourself, upside down, obviously. So then you will realize what I said is correct. This is very important, right? Again, here, because of there is a gap of 2.5 centimeters, they are not meeting at all. And as I told earlier, there will be the distance between the posterior sutures. Indications for forceps. Now, this is very, very important. Yesterday, I was talking about indications for vacuum. So indications is basically to help the mother to push or to help her in getting the baby out, exhausted mother. As I told you yesterday, forceps is better in the sense at any cost you can bring out the baby. Whereas in vacuum, mother's cooperation is required, secondary powers are required. And of course, there are some contraindications like you cannot use vacuum in preterm baby, face presentation, breech presentation, HIV patients. If there's big caput, all these places you cannot use vacuum. Whereas in forceps, you can virtually use forceps for any situation. If there's an undue delay in second stage, if there's exhaustion, right? And to cut short the normal second stage, that is prophylactic forceps in case of heart disease, preeclampsia, and anemia. Now, some of you must be thinking, I said I can use forceps in any situation, but can I use forceps in a malrotated head? No is my answer, but people who believe in Killen forceps, they say, yes, you can use Killen forceps, use forceps, rotate the head and reapply and pull the baby out. As far as my belief goes, there can be only one contraindication for forceps, which is a transverse slide, right? Otherwise, forceps can be used in any situation. Fetal indications, fetal distress to quickly remove the baby or deliver the baby. Cord prolapse, again, it's an urgent situation. Vacuum may sometimes be delayed there, so forceps is better. But again, if the head is slightly high, vacuum is better. Preterm baby, of course, forceps. Vacuum is contraindicated there, isn't it? Face presentation, vacuum is contraindicated, forceps is indicated. After coming head in the breech, again, Piper's forceps is the one which we use. Vacuum cannot be used. What are the prerequisites? This is a very, 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 very stock question. Every single student will be asked about this question if you are given an instrument called forceps. And then undergraduates by heart this, they make a mnemonic out of it, like forceps. Uh, I really don't like to make mnemonics to remember these kind of things. These things are better understood and remembered. Yes, of course, there are some, what are the states of Northeast, there is a mnemonic. Northeast itself is the mnemonic. That is okay because there is no correlation at all. But here there is a lot of correlation, right? So as far as mother is concerned, the bladder and bowel should be empty. This is common sense, no brainer. You don't have to remember this. If the bladder is full, if the bowel are full, and there's a pelvic curve like that, you will just nicely tear all the bladder. And when you remove finally, you will nicely tear the rectum. So it goes without saying. You don't have to remember this. It is common sense. It's very, very common sense. Bladder and bowel should be emptied. Number two, cervix should be fully dilated. Otherwise, how will you put the forceps on the head? Do you want to remember this? It is a no-brainer again. The cervix should be fully dilated and head should be just almost out of the cervix in the vagina. Then you will go and apply that, isn't it? Otherwise, what will happen? You will be applying forceps on the cervix with the head. That will cause a tear of the cervix, very bad tear of the cervix. Number three, membranes should be ruptured. This is also no-brainer. If the bag of membrane is there, you will be just compressing the bag of membrane with the forceps. So don't have to remember. These are commonsensical things. As far as baby is concerned, head should be fully rotated, at least not more than 45 degrees. So when the head is fully rotated, I told you the cephalic application and pelvic application will coincide. So these are all things to be just uttered without using your brains. No memory allowed here. No mnemonic allowed here. These are commonsensical for postgraduates. What are the preliminaries? Prerequisite is different, preliminaries is different. Anesthesia is very important whenever you use instrumentation, even episiotomy. You can give a local anesthesia. That should be good enough sometimes. Pudendal block, nowadays, most of us don't give. Epidural, if the patient is already on, then of course, if you want, you can give an additional infiltration to alleviate the local pain. Liberal episiotomy, I believe very much. There's a lot of controversy surrounding episiotomies. People say, don't need to give episiotomy, some tear is all right and all that. We have seen even if you give episiotomy, that episiotomy extends sometimes when you use the instruments. So better to give episiotomy. The question is whether to give episiotomy before applying the forceps or after applying the forceps at the time of traction. This is again, I will leave it to the situation because sometimes the intratus can be so small, you can't even introduce the instrument. So better to give episiotomy early. The people who argue saying that don't give episiotomy at the time of insertion because there will be a lot of bleeding because you will be pulling back, coinciding with the uterine contractions, isn't it? Though uterine contraction is not necessary for forceps, unlike in vacuum, it is always preferable to pull the baby out or apply the traction coinciding with the uterine contraction. There will be some amount of uterine contraction anyway. So in between the contractions, you don't pull. During the contractions, if you pull, it is a better thing to do. So when you're waiting, there will be a lot of bleeding. But I leave it to the situation there. If you cannot introduce an instrument, it doesn't make sense not giving episiotomy. You have to give episiotomy. Okay. Empty the bladder with a red rubber catheter. Yes, I told you prerequisite is an empty bladder, but when waiting, sometimes the bladder will be filled up, especially if the patient is on some IV fluid or she has not passed urine for a long time. So make sure that 100% bladder is empty by putting a just red rubber catheter, not a Foley's catheter. PV to note the rotation of the head. This is a very, very important thing. This will also tell you whether there's caput, because sometimes what happens, you'll apply the forceps on the caput and it will slip. So you have to do a PV to see whether the rotation is complete. Always sagittal suture should be in the midline. That's the best scenario. and then kaput should not be so much. Procedure. Now, procedure consists of three things. Number one is application. Number two is locking. And number three is traction. This is very, very important for you to understand this. And this will be asked in the exam. Even while writing the notes of the forceps, these three steps have to be written. That application was easy, locking was easy, traction was easy. All the three things should be mentioned. Let's go one by one. Application. Now I come to the actual procedure. I don't have a forceps, but you can imagine, like I'm imagining, the forceps blades should be held like you hold the spoon and fork with just two fingers. That will, you're using only lumbricoids and other smaller muscles of the hand, so that you don't use a lot of force. And these three fingers will just not allow you to go any further. If you hold any instrument like this is to stab and kill a person, right? So don't hold the forceps with the fist. It will be held like a finger. And now the left blade is held in the left hand. The right blade is held in the right hand. This is another common thing that is. So left blade I hold it like this. And first application is left blade because it's a lower blade. The right blade will sit on the left blade. So hold it like this, and it is applied posteriorly first. Okay, it is not directly applied. So I'm using the right hand now. Why? Because the right hand is pushed between the head and the posterior vaginal wall, so that when you're applying like this, you don't go and poke the rectum. So this will guide. So you slip the blade on your right hand posteriorly first, and then slowly guide it to the right side. And it will go and stay there. If it has been properly applied, when you remove the hands, the blade will stay there. Okay? So I'll repeat my action. You are holding the blade like this. First, of course, you have to do a phantom application and find out which is the left blade and which is the right blade. Hold it in front of the mother. The concavity should be upwards. So, and when you separate, you will straight away get left blade is lower blade, and you hold that blade like this and put the hand with the blade should be on the hand. It should slip on the hand, and of course below the head. And you first apply posteriorly and slowly turn and put it to the right side. And when you leave it, the blade will stay there. Still, you have to ask your assistant to just depress the handle, because the right blade is going to be on the top of the left blade. If the blade is up, then you cannot apply. So even though it stands there, ask the assistant to lower the handle of the left blade. So left blade is applied first, held in the left hand. I told you that. Introduced posteriorly first, like this. Here they have shown only two fingers, but I am showing the whole fingers there, like this. And then slowly move to the left of the head. Right hand guides that. Okay. And then assistant holds it depressed, so that now the right blade I can come out. So the right blade is held in the right hand. Now, right blade need not go down, because the handle will there. You are just making a noise there. So, okay. Now, right blade should be guided by the left hand, because again, when you apply force, again, when you hold like this, you won't be injuring any structure. If you hold like this, if you pull that, you will get left iliac vessels and everything in your forceps. So you are not planning to stab the left iliac vessels, right? So the left hand will guide now. The right blade will go directly onto the right side of the baby's head, and it is going on top of the left blade. The left blade is held depressed by the assistant. It will go and sit on the left blade. And then, of course, you just negotiate a little bit and see whether they're applied properly. And if your selection is right, if the rotation is complete, they'll beautifully go just like a small super slide, like a knife on the butter, and then they will just lock properly, right? So held in the right hand, directly introduced onto the right side of the head, left hand guides that like this. You see, the left blade is depressed and kept. The right blade is going on top of that. It's going onto the right side. Okay, now locking. First is application. Second is locking. Third is traction, right? So locking, when applied correctly, they articulate with ease and get locked nicely. But you don't keep it locked. Just first see whether it is locking or not. Don't keep it locked. In between the contraction, keep it unlocked. During contractions, just lock it and pull. Okay? Clear. Handle should never be forced to lock. If you have to force to lock, that means there's something wrong with your application. Maybe head is not completely rotated. Now, traction. Traction is a very, very, very important thing. The third thing. First one is application. Second one is locking. Third one is traction. Now, traction in the outlet forceps, it is basically helping the extension of the head. So there is no need to pull down. Okay. So that's a straight away. First you pull horizontally forwards, and like this, and then upwards. So you are only helping the extension of the head. This question is asked in the exam. What is the job of the outlet forceps? The answer is extension of the head only. Whereas low forceps has to pull the baby down a little bit, then horizontal, then upwards. Clear? Look at this picture very clearly and imprint in your mind. So like this, horizontal and upwards. Whereas traction in low forceps, head is +2. So first downwards, you have to pull the baby downwards. And then, of course, like a outlet forceps, horizontal, and then upwards. Okay, clearly. Keep this picture in your mind. Only difference is first you have to pull downwards because head is slightly high. Okay, so 1, 2, 3 steps. Whereas in outlet forceps, 2 and 3 only. First step is not required. So in occipito-posterior, what happens? It's a face to pubis delivery. So you, as you can see beautifully, this baby, first horizontal and then upwards. Whatever, whether it is face to pubis or whether it is up or down, it is horizontal and upward traction. That's the basic thing. Only thing is, the difference in occipito-posterior, here it is flexion of the baby's head. There it is extension of the baby's head. That's all. It is by increased flexion. As far as face presentation is concerned, again, whenever I told you in another class, occipito-posterior, face to pubis, whenever the word face comes, F. And whenever the actual face presentation, also F. The delivery is by flexion. Face to pubis, flexion. All are F. Remember that. So downwards and then upwards. Our pulling is always downwards and upwards or horizontal and upwards. But the baby in anterior positions, it is extension. In posterior position, it is flexion. In face presentation, it is flexion. Clear? Traction in after coming out of the breech. See here, Piper's forceps, which has got a long shank and perineal curve will be very minimal. It is first downwards. Again, baby has to be delivered by flexion, You have to cause flexion. If it is extension, then the baby won't deliver. And this is same as Bern-Marshall technique. Instead of that, you are using forceps. One of the 3 methods, Bern-Marshall technique, Mauritius-Mealy technique, and Piper's forceps. Downwards, posterior, and then arc upwards. Our pull is always downwards, horizontal, and upwards. But the baby does different things. In breech also, baby is, because face is the presentation in breech after coming head. Whenever face comes, it is flexion. Remember that. Now I come to the documentation. Very, very important. If you have not documented, you have not done. I used to repeat this to my PGs many, many times. If you have not documented, you have not done. Documentation is very important. How do you document the forceps delivery? You must write what are the indications for forceps delivery, what was the type of forceps used, whether outlet or low forceps, what was the station of the head, obviously low forceps +2 and outlet is +3. What was the position? Was it completely rotated or whether there was short of rotation within 45 degrees? Steps of procedure. You have to write application was easy, locking was easy, traction was easy. Or if there was a problem, you write the problem. But these 3 steps you must write. Outcome. What was outcome? Baby cried immediately. Baby had no problems or some injuries, some problems, whatever it is. And condition of the mother and baby should also be documented. These are the steps of documentation. Very, 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 very important. What are the difficulties? Again, 3 steps of forceps application, locking, and traction. Difficulties has to be at these 3 levels only. Application, maybe because if it was an incompletely dilated cervix, that's why you could not apply properly, or it was a transverse head, you could not apply. Locking was difficult, again for the same reason, improper insertion due to the wrong application. Left handle was not depressed enough by the assistant, you can shout at the assistant to depress it proper so that it will lock. Entanglement with the cord. So that's why if any, not only cord, any other structure comes in between, you cannot lock properly. Traction, undiagnosed occipital posterior. You are pulling in a wrong direction. You should always pull upwards. As I told you, whether it is anterior position, posterior position, horizontal upwards, maybe sometimes little downwards just to bring the baby little down, then horizontal upwards. No matter what is the position, okay? So don't worry about it. Now, traction, sometimes you need a force. I remember this very vividly once. The senior professor was pulling the forceps and she could not actually manage. So she looked at the intern and shouted, "What are you doing? Just pull." So he went and hugged her and pulled her. You know, that is a joke. And of course, wrong direction of pull also will cause problem. What are the advantages of forceps? Virtually no contraindications. But as far as Muralidhar Pai is concerned, there is one contraindication, that is the transverse, deep transverse arrest. There it is, of course, vacuum in case of multi, if there is a lot of space, or best is cesarean section. Don't use Killen forceps. No need of maternal forces at all here. 100% obstetrician force, unlike in vacuum. It can be used in preterm babies. That's the advantage. Face presentation and after coming out of the breech where vacuum is contraindicated. But there are some disadvantages. It cannot be used to rotate the head in modern obstetrics and in deep process. Same thing I'm telling again and again. Okay, injuries to mother and baby. There can be skull fractures, skull, lacerations on the face and all those things. Skill difficult to acquire. It's not as easy as vacuum. What are the complications? As I said, injury, vaginal lacerations, vaginal cervical tears, lacerations, perineal lacerations, episiotomy extension, even if you are given episiotomy, traumatic PPH and shock, sepsis. As I said, PPH means shock and sepsis are part and parcel of the game. SUI and prolapse, it's a remote problem. Fetal, again, injuries, whole lot of injuries. Forceps marks can be there, which will disappear, no problem. But facial nerve injuries will take long time to recover. Ocular trauma can sometimes occur. Cephalomatomas and intracranial hemorrhages and skull fracture. Luckily, these things will heal given over time, but those days are very difficult till it heals. Asphyxia to the baby and cerebral palsy very remotely. I will wind up this talk by two concepts. One is trial forceps, other one is failed forceps. What is trial forceps? Now, the word suggests try, isn't it? Trying forceps, one last ditch attempt. Here, word is this with the knowledge. Green I put. With the knowledge of possible failure. That means obstetrician is an erudite person, is a smart person. He knows what he is doing. He just wants to try one last attempt, maybe in the OT itself, so that he can avoid a cesarean section. That is the meaning. I'm using so many adjectives, right? So it's with the knowledge possible failure. Forceps delivery is attempted in double setup means again, OT. She is prepared for cesarean section if it fails. So this will not, even if it fails there, it will not be called failed forceps because obstetrician is not forcing himself or he is not causing any injuries. He will try. If it fails, he will just give up. He is prepared for cesarean section. He will deliver a healthy baby. See the difference. Okay. If not successful in first attempt, abandon the procedure. Don't use any other sequential instrument like vacuum. Straight away cesarean section. No sequential vacuum application. Whereas when you say failed forceps, here also the obstetrician is trying to deliver by forceps, isn't it? Then what's the difference? The difference is that forceps delivery is attempted with predetermined mindset. Hook or crook, he wants to deliver the baby vaginally, which is wrong. Without anticipating failure. He's so bold, confident, overconfident, rash obstetrician. He just says, I will apply forceps and deliver. He is not prepared for cesarean section. He says, give me forceps, I will deliver. He's a big show off. Hence, not in double setup and failed to deliver vaginally and deliver. Somehow he will deliver, but it's a dead baby or a moribund baby. That is called failed forceps. In the earlier occasion, you have failed to deliver vaginally. All right. But you have delivered successfully a good baby, healthy baby, cesarean section. You just attempted once. That's called trial. This is called failed forceps. Reasons for failure is wrong identification of position, service between blade and head, and whole lot of mess there. So thank you very much. I hope these two lectures were very useful, not only to the PGs, for all practitioners also. However, whatever is your choice, you can use. If you are comfortable with vacuum, go ahead with vacuum. If you are comfortable with forceps, you can do forceps. And in vacuum, yesterday, I forgot to tell you, Kiwi's cup. There's a, just with the hand itself, you can do this and you can apply that forceps. Otherwise, you can use a mechanical cup. Most of the places now have the electric vacuum. So thank you very much. I'll come up with more topics in coming days. I hope you do well in the exams. Exams are very fast approaching. Some universities it is from 15, some universities maybe earlier than that. All the best. Do well in the exams. Thank you so much.